My name is Lisa Leonard, I'm a consultant orthopaedic surgeon in Brighton, and today we're going to take you through me and a registrar doing a DHS procedure, which is a dynamic hip screw for an intertrochanteric femoral fracture. Right, and here we are positioning the patient on the table. Very important to put padding around the heels, particularly in the feet. As you can see, they go into fairly tight set of stirrups which hold the feet attached to some metal plates, and these are attached to the table higher up. Shortly you'll see they take out the underneath, so the black padding on the base of the table is removed to give access to the patient, so completely suspended by that foot attachment. Very important therefore that that's extremely secure and also very comfortable, so that the ankle's not held in a peculiar position. And you need to get the unaffected leg out of the way so that you can get good access with your image intensifier, which you always check before we start. Coming through for this lateral, you must just watch that the radiographer's checking not to catch the foot as they come round. It's very easy to catch. Once you've got an adequate picture on the check x-rays, both AP and lateral, then you can withdraw the x-ray machine, set up the rest of the draping. I normally clean the skin before we do the skin prep, just with Chlorhex and water, and then this is Chlorhex, which I normally like with staining in, which is much easier to see where you're going. Once that's dried, you can apply, it's a large adhesive drape. You need to make sure that, obviously the adhesive drape is in the centre of your surgical field, and it's surprisingly easy to misplace this, so make sure that the greater trochanter is in the middle of the sticky bit. And then as you elevate the plastic drape, it goes over the bar at the top. Keep the central part lax, you can see there, to allow the image intensification machine to come in and not rip the drape off the patient. Here we're using a wire just to locate approximately our entry point so that we can put our skin incision in the right place and not go too proximally or too distally. And here we're making a skin incision, just a longitudinal incision straight through the fat, and there you see the fascia lata just coming nicely into view. Here we've split the fascia lata already, so we're down now onto vastus lateralis, which you can see in it with its filmy fascia over the top, bulging out towards us. Now, you can lift this up and go posteriorly and lift the whole muscle layer up to gain access to the femur. But there are quite a lot of perforating vessels posteriorly, so I tend to just split that in the midline, which we'll see in a moment. It's just feeling there for the trochanter to orientate. Keep slightly posterior, because nearly always the head is slightly anterior to the shaft, and so you'll be aiming up. So you don't want to be fighting off muscles while you're putting in your guide wire and reaming later on. Just using a periosteal elevator there, blunt dissection to split the muscles, the muscle fibres, and then elevation to get them off the actual bone. You can see lots of little muscle fibres there, which you just need to split, and then you can see the bone coming into view, the shaft there of the femur, where your plate's going to sit. So all that tissue needs to come off the bone so that it's not lying necrotic below the plate. The guide pin goes through a fixed angle device so that the angle that you insert the pin at is the same angle as that of the plate. And you use the x-ray machine at this stage, you can see top right, to guide the entrance point for your pin, both on the AP and the lateral. You aiming that up into just slightly inferior and just slightly posterior on the femoral head on both views. And you may find that you need to adjust this very slightly in order to have it in the middle of the femoral head at the end. Very important that you obtain views where the tip apex distance is minimal. This is distance from the end of the screw in the end ultimately to the centre of the femoral head on both your views, and the combined distance there should be less than 2.5 centimetres altogether, so that reduces your cutout rate. So here we can see, particularly on the lateral, very nicely centered pin and in the AP as well. So happy with that. So once the wire is, and this is probably the most essential step, getting the wire in the right place. Once that's in, we're now putting in a second pin so that when we ream, it's a very large reamer, you'll see in a moment, when we ream over the first guide wire, we don't spin the femoral head out of position, because at the moment it's very nicely lined up. The cortices are lining up nicely on the film. So now we're measuring the length of the original guide wire to determine the length of the drill first of all, and then the screw. And most people take 5 to 10 millimeters off the length that they measure for drilling. I generally put a screw in of the correct length. Here we're just checking an image intensification film as you start to ream to be sure that you haven't pushed the pin through into the acetabulum and then into the pelvis. Once you've reamed, you then put the screw of the correctly determined length in using a special screwdriver with a guide over it that slots it into the right place. The handle of the driver needs to finish up parallel with the plane of the femur, and this coincides with 2 flat flanges on the edge of the pin, the screw that you put in, which will then allow the plate to sit on nicely. This is a quick view of the plate going on there, but you just sometimes need to jiggle that around a little bit to get it on flush with the bone. Once you're happy with the plate sitting very nicely flush on the bone, just check that the distal part of the plate is not too anterior or posterior, so the screws are going to be in the middle of the femur. And we're now using a smaller drill to put in the shaft screws through a drill guide there. It's a depth gauge, a little flange on the end that catches the far cortex and then tells you how long the screw is. Some sets now have self-tapping screws, some you still need to tap the screw thread. And you do the same for each of the usually 4 screws. They do make different length plates for different fracture configurations, but a 4-hole 135 angled plate is the commonest one to be applied. 135 referring to the angle of the femoral neck to the shaft. And you should get a good nice bite on the cortex as you put the screws in. Final check films show the screw nicely positioned in the head on the AP, and you must check a lateral of course as well, and slightly divergent screws in the shaft. You try and aim them slightly away from each other so you don't get a row of screws all in line. Very thorough lavage. That was shortened version. I used copious lavage for all of these operations to be sure you try and dilute any possible contaminants. And then repairing in layers. Sometimes you don't need to repair the muscle fascia, but here we've put a layer in the vastus lateralis fascia, and then repairing through in layers using absorbable sutures here. Interrupted stitches for any layers that you feel you don't want to fall to pieces. And then for the skin, usually a 3/0 or 4/0 vicryl subcuticular closure with some steri-strips. This gives a neat wound, and I think patients prefer that to clips, although I will use clips if the patient requires very speedy closure. And then usually an op-site dressing. That's it. I don't use a drain normally, although lots of people do.